So as people are joining, I am just going to get started now. So welcome to our final webinar of the year. You may see through it, there's a couple of Christmas themes. It is December after all, but what a great year it's been for the webinar program that we've had. This is, as I said, our final one of the year. We've had over 600 attendees attending webinars throughout the year, covering topics such as women's health, access to justice as a public health issue, violent risk reduction, a quick guide to the public health systems and health inequalities, sustainability and public health, and a couple of weeks ago we held one on creative health solutions. In this webinar, we're looking at epigenetics, how behaviours and environment alter your genes. But Holly, if you can go on to the next slide, please, for me. The one after that, sorry. I'm Nick Loudon. I'm the project manager for public health here at Health Education England Northwest. I'm just going to do the housekeeping and a few thank yous and talk to you a bit around the Population Health and Prevention Network. So the housekeeping, a question that appears on the chat in every webinar we do is, will the slides and recording be made available? The answer to that is yes, it will be. All the slides and videos will be uploaded to the Population Health and Prevention Network website, which will be shown on the next slide. During the webinar, please keep all mics on mute and cameras off. There will be opportunities for questions at the end when you may take yourself off mute and show your camera. But during the session, it would be great if people or the participants, attendees, are able to just put questions that you may have into the chat, and we'll look at them throughout. And whenever the time is appropriate, we can ask those questions to our speakers. If there are any technical issues, please email Holly, but most of you are on the call now, so hopefully that's all gone fine. But if you could please email Holly, and her email address is on the screen. Let's go on the next slide, please, Holly. So before we get into the main topic, I want to make you all aware of the Population Health and Prevention Network. So what is it? It's a multi-professional public health network funded by Health Education England, and we work across the Northwest. Some of the key functions that we do include championing the importance and contribution of the wider public health workforce located across a wide variety of healthcare and voluntary care settings. We're a single point of contact for signposting to education and training opportunities here in the Northwest, including public health news, events like this today, information and resources. So we help with the diffusion of ideas, research and information associated with public health, including sharing public health that we do and our colleagues do in many different organisations that support the wider public health. To find out more about us and the work that we do and the work our partners do visit our website at mwpopulationhealth.nhs.uk and follow us on Twitter. So all that's left for me to say today is a few thank yous in advance. First of all, to Joe Ward, our webinar curator and chair for the day. Thanks to all the work that you've put into bringing this webinar together, as well as all the work for all the webinars you've done this year. They are a really key part of our work programme, and without your hard work, they wouldn't have been the success that they were. So thank you, Joe. Our webinars are nothing without our speakers. So for all the speakers who have briefly met before and we've been working with over the last few months, thank you for all the work you've done producing the slides and videos. This isn't a topic I know a lot about, but I've seen the slides in advance and it's something I'm really looking forward to hearing and learning more about. Thank you to Terry, Holly and Christina. They're crucial to the success of these webinars. Everyone is at the webinar. You're all here, you're in the right room, the right speakers are here. That doesn't happen by mistake. It's down to the work of Terry, Holly and Christina. So thank you. As this is the last webinar of the year, I just want to recognise and say a special thank you to Holly and Christina, who are leaving HEE tomorrow for new roles. The work you've done for the network while you've been at HEE has just been amazing. So thank you. And as well as this, some of you may know, and I hope I don't embarrass her with saying this here, but this will be the last webinar Alison Farah will be attending in a work capacity. You're more than welcome to attend other ones in the future whenever Alison retires in February. So Alison has grown the network from nothing to what it is today. She will, I was thinking about it earlier, she will have supported thousands of public health workforce over the years. So thank you for everything you've done for the network. I guess enjoy the retirement when it comes. But on that note, I'm just going to pass you over to Jo, who will chair the webinar. Over to you, Jo.
Thanks very much, Nick. So yeah, we've got a really exciting lineup of speakers today. Majority have been drawn from the Northwest Genomics Medicine Science Alliance, who've got a fabulous website and are probably one of the best kept secrets. So we really hope that you engage with that website after today's session. Nick's already outlined the overall content in terms of how do our behaviours and environment impact on our genes. I think what we wanted to do today was to mainstream the genomics discussions and epigenetics as part of a wider public health discussion, because as many people often say that your genes are not your fate, but sometimes people are in environments which they have little control over. And as a public health service and a population health approach, we need to understand what those impacts might be. So today is really a look back in terms of, some of you remember the 100,000 Genome Programme that was launched under David Cameron. Lots of work and development and training happening, and also in terms of mapping genes to inform understanding. And then we have the NHS England, basically genomic medicine service alliances in each region. And I think what we really want today is to put those services, particularly the Northwest, on your radars and to support understanding about why genomics is important to you as a clinician, as an individual operating across the health and social care landscape, but also as a potential patient as well. So without further ado, I'm really pleased to introduce Lisa Dowell, who was around with the original 100,000 Genome Project, who's got a long history in terms of education and training. She's going to set a context for us. And then we will move swiftly into a video from Jessica Keane, our pharmacy specialist. So I'll hand over to Lisa and we'll take it from there. Thank you.
Thanks so much, Jo. As Jo's introduced me, I'm Lisa Dowell. I'm one of the genomic educators for the Northwest Genomic Medicine Service Alliance, hereafter known as the GMSA for this talk. And it's I'm really delighted that I've been able to come and speak to you today. And if I could have the next slide, please. So the aim of my very quick little mini session is to look at genomics versus genetics. What are the differences? As Jo mentioned, the 100,000 Genomes Project, just to give you a little bit of history, and the GMSAs themselves, but most importantly, what it's going to mean for your patients and your communities. Next slide, please. So genomics versus genetics. So genetics, I would imagine, is something most of you will have heard of, and terms like DNA are sort of battered around a lot. And it refers to the study of genes and the role of inheritance. But the genomics is a more recent term, and that describes the study of all of a person's genes, i.e. their genome. And that includes the interaction of the genes with each other and with a person's environment. Next slide, please. So genomic variations, you may have heard them referred to formerly as mutations, but we use the term variations now, also known as polymorphisms. And genomic variation describes the differences in sequences of DNA between individuals. So they're absolutely essential and they contribute to biological and visual differences, but they can also directly cause rare health conditions and result in risks of developing common health problems. And the difference is how each of us respond to that and how we respond to the medicines that are being used to treat those particular illnesses. Next slide, please. So the 100,000 genomes, this is just a very, very brief potted history. As Jo mentioned, it was announced by David Cameron in 2012, part of the Olympic legacy, and then launched officially by the Secretary of State for the NHS's 65th celebrations. The new sequencing centre, which was cost 42 million down in the Biodata Innovation Centre at Wellcome Genome Campus in Cambridge, opened in 2016. And as this was continuing, the 100,000 Genomes project was being rolled out across England. I'm going to refer a lot just to England because it was broken down into the different countries of the UK. So Genomics England was being rolled out, and we were lots of hospitals, and I'm sure those of you listening today will have assisted with some of those recruitment. So thank you very much for that. And we actually reached the goal of sequencing 100,000 genomes in England in December 2018. Next slide, please. So based on evidence from the 100,000 Genomes project, the first NHS Genomic Medicine Service launched in October 2018, and it's been helping provide diagnosis and treatments that wouldn't have been found otherwise. So, for example, there are 5 different babies, as you can see here, and they would be having 5 different treatments for, in this case, neonatal diabetes. And whereas before there would have only been 1 treatment for all of these babies, thanks to the genome, thanks to the isolation of the genomes in each of these babies, they were able to get the right treatment the first time round. Next slide, please. So the NHS Genomic Medicine Service today, as you can see, there's an awful lot going on, but mainly for your benefit, it's made huge strides in equitable care for all, and it's been consistent in building a database so that all care and outcome will be the same across the board for all patients in all areas of this country, and working towards assisting public health. We're assisting with NHS services in getting everybody the right care the first time round correctly, no matter what area they're from, no matter what their healthcare provision. Next slide, please. So the government then established the GMSA, the Genomic Medicine Services Alliance, in 2021. And the main aim of these GMSAs, you can see from this slide, they're all across England again, is to deliver faster diagnosis and more effective treatment for patients. Next slide, please. So the Northwest GMSA, so I imagine most of you are working in the Northwest, so this will be the one you're most interested in. So we are mainly interested in equity of access to underserved communities and taking the very important information that we collected from the 100,000 Genomes project and implementing it. And we're also helping to assist care across the country. So there we are in pink, just in the corner. Next slide, please. So our Northwest Genomic Medicine Service Alliance is one of 7 across the region. As you can see from this slide here, we have a very, very large square mile area and population of just under 7 million. We're also one of the most culturally diverse in England, with over 50 different languages spoken. So we work very closely with the GMCs and the Northwest Genomic Laboratory Hubs, the GLHs, in Manchester and Liverpool cities. So next slide, please. So our team, the team that will be working with the majority of you, is here to support the NHS and healthcare colleagues so that we can use genomics safely and effectively. We want to help embed it into your clinical practice and also provide learning and education so that we can adopt it permanently into patient care. So our team is made up of, next slide please. So this rogues gallery is, as you can see, there's a lot of investment and time been spent in building an effective GMSA team for the Northwest. And I'm sure you recognise some of these names, but we have clinical alliance directors, and we also have professionals, people who, 2 of whom are speaking today on this slide. Next slide, please. And we also have an education and research team, which I'm part of. We have programme management, and we also have communication, engagement, equality and diversity. And Manaza here on this slide will also be speaking to you today. So as you can see, there's a lot of very experienced professionals that are behind this extraordinary team. Next slide, please. So the GMSAs will be helping to review equity of access for patients. So patients that have perhaps been underserved before by the NHS, and we want to assist their journey embedding personalised medicine into mainstream healthcare. But most importantly, we need to ensure that the staff have an understanding and a confidence to utilise genomics safely, because it is going to save staff an awful lot of time and patients also a lot of time in their journey to better health. Next slide, please. So currently we're working in partnership with a number of different areas, but most importantly, we have an excellent patient and public volunteer group that we work with. And we've just recently had our AGM last week, and it was a great success, and we feed regularly stuff back to them and they feed into us ideas. But we also, as you can see, work with Regional Cancer Alliance, with Health Education England, with the GLHs and AHSN's pathology alliances, primary care networks and other clinical genetic services. So we have excellent relationships with them. Next slide, please. So finally, as we know, understanding a role in our DNA from the research we've done holds the key to finding treatments, but it also helps will help us in the road to recovery of other new illnesses that may come along. And just because we haven't found a cure currently doesn't mean that we're not going to find it in the future. So we're here to help. We are working with making strong collaborations across large geographies, but most importantly, our patients are at the heart of everything that the NHS GMSA are doing. It's the most important part for us, that patient journey is shorter, more effective on the road to wellness. Next slide, please. So thank you so much for listening. Our details, our website's here, and also our Twitter handle. Please feel free to make a note and follow us. If you have any questions, I understand we're having questions at the end. Myself and Glenda Beeman, who is here also on this call, will be happy to answer any questions. Thank you, Jo.
Thanks, Lisa. And we're going to move on to a video from Jessica Keane, who's the pharmacy lead at GMSA. She's been qualified since 2008 and has a really strong commitment to ensure genomics is embedded in all clinical pathways. And one of the things that I wanted to share, and where I got interested in the genomics discussions, was the fact that I hadn't realised that if you have a particular gene, that you can't metabolize codeine, and that means lots of people are not getting pain relief. And wouldn't it be wonderful if we understood the detail of how drugs interface with individuals' genetic makeup and whole genome? So Jessica's work is very much around medicine optimization, but most importantly, it's as well as reducing risks from toxicity. So could be in the similar way to the example Lisa used. We have two adults who have breast cancer, but have very different genomic footprints. And for one, they could tolerate much less chemotherapy, etc. And if we knew that in advance, we could reduce overall harm. So a quick introduction to a complex area, but I'm sure Jessica's video will enlighten us further and whet your appetite for more information. So if we move over to that, and also if I just remind people as well, before we get into the meat, shall we say, of today's discussion, there is a quick survey in the chat just to flag really where you're at when you started the session, and then we'll ask the questions at the end to see what journey you've been on in terms of today's learning and the learning for ourselves as well in relation to future structures. So do have a look at the chat, and the video will start shortly.
Hello, I'm Jessica Keane. I'm the pharmacy lead here at the Northwest Genomic Medicine Service Alliance, and I'm sorry I couldn't be with you in person today, but I hope you enjoy this recording around genomics enabling personalised medicine for the Population Health and Prevention Network meeting today. And the aim of this session is really just to raise awareness and increase your knowledge around how genomic medicine can improve patient care and population health. So really, I wanted to highlight in this first slide that we can use genomics to personalise treatments to the individual, and we can do this in a number of different ways. Firstly, we can do this by using genetic material from the person themselves and then target treatment specifically towards the genetic cause of their condition, or maybe to adapt the treatment based on how their body might handle the given medicine, and many other ways. Secondly, we can test the DNA of a person's cancer. This will have distinct genetic variation from the individual DNA, and that can therefore be specifically targeted in the treatment of their cancer. And thirdly, by using genetic material from an organism, a bacteria or a virus. So if an individual has a viral infection, for example, we can genetically sequence that virus and then tailor treatments accordingly. And we've seen that done with the treatment of COVID-19. And so genomics can really enable personalised medicine in a number of different ways, from novel therapeutics right down to optimising existing treatments. And I'll just give you a couple of examples of how that can be done. So it could be things like gene therapies, where we use new technology to deliver tailor-made genetic material into a patient's cells to treat disease. One example of that is CAR T-cell therapy for B-cell lymphomas and leukemia. We can also use genomic information to create new targeted treatments based on an increased understanding of the genomic basis of the disease. So we talked about targeted cancer treatments, but also for things like cystic fibrosis, where drugs like Kaftrio can target the specific CFTR gene variant in patients with that homozygous deletion. We can also use genomic information to stratify treatment based on precision diagnostics. So in things like monogenic forms of diabetes, they have specific treatments that differ from the standard care provided for type 1 or type 2 diabetics that we're more traditionally used to. And so that appropriate diagnosis is really essential for those patients. Again, we can use genomics to predict drug resistance, so viral sequencing, as I've just mentioned, but also to predict antimicrobial resistance patterns in things like TB. And then finally, things like pharmacogenomics, which guide treatment decisions and dosing using a patient's genomic data to predict a drug response. So this can improve drug effectiveness or reduce the risk of side effects by using preemptive genetic testing to determine patients who might be susceptible to severe skin reactions, by doing things like HLA genotyping before we start certain drugs like abacavir for HIV, which is a commonly recognised example. So why does pharmacogenomics matter? Well, medicines are only effective between 1 and 2/3 of the time. It has been estimated back in, I think, about 2009 that around 1 in 15 UK hospital admissions are related to an adverse drug reaction. That's an ADR, a very high cost to the NHS. At the time, that was estimated around £600 million. It's now thought to be much higher than that, at probably between £1 and £2 billion, and closer to 1 in 6 hospital admissions in the UK may be related to an ADR. A recent study has also shown that for drugs where there is clinical guidance around pharmacogenomics, about 1 in 5 of all new prescriptions for those drugs in UK primary care are estimated to have a drug-gene interaction. That is, a person who's prescribed the drug also has a relevant change in their DNA that would impact how they handle that medicine. And finally, multiple different studies have shown that almost all of us will have a variant in one or more pharmacogenes. Generally, the estimates are upwards of 99% of people being affected. And so I must highlight when I talk about this that the reasons why medicines are not always effective or why they might cause adverse drug reactions are not always linked to genomic variation. There are other differences, such as demographics, maybe kidney and liver function, or differences in the other medicines that people might take that can impact whether a treatment is effective for them, but not another person who takes the same medicine. One of the ways that a person's genetic variation might impact their response to medicine is if they have a change in the gene that encodes for this enzyme, enzyme B. So when they take drug A, they're not able to convert the drug into its active form, and therefore drug A doesn't work for that person. A person's predisposing pharmacogenetic variation is therefore just one of a number of factors that you can see in this diagram on the right, which will impact whether or not they may respond to the medicine or have an adverse effect. Additionally, poor adherence, so whether or not someone takes their medicine as it was prescribed for them, can impact on the efficacy of the treatment. This may also be linked to their genomic variation. So if a person has experienced a side effect, or if they feel the treatment is not working for them, they may simply stop taking it, and that then impacts on the efficacy of the medicine as well. I want to take you through a short patient story now to try and highlight the possibilities with pharmacogenomic testing, but a quick word of warning that the next slide contains a photograph of a skin condition, and some people may find this upsetting. So this patient story is around a young lady who's a 19-year-old female some years ago now, who had epilepsy, which was well controlled on a common anti-epileptic known as sodium valproate. It has been associated with fetal abnormalities in pregnant women and was therefore to be completely avoided in women of childbearing age. And so at that time, it was very common to switch to an alternative anti-epileptic in this particular group of patients. So the patient was counselled by her doctor and switched on to carbamazepine, with one drug being withdrawn slowly and the other one being carefully increased. She then developed a mild itch on her arms, which progressed over a number of days. And after about a week, she went back to her GP because of this problematic itch. And the GP diagnosed this as being a reaction to her new washing powder that they started using at home. So that was fine. Off they went, and she was more cautious with her laundry. But about a week later, she started to develop a sore throat, and one day ended up in bed with flu symptoms. Her rash was not really resolving. She was living at home with her parents, who went out to work and made sure she had enough paracetamol and told her to rest up. When they got home, she was actually minimally responsive, and so they phoned an ambulance and she was admitted to A&E. And she actually had been developed a severe skin reaction called Stevens-Johnson syndrome, which is one of a range of serious skin reactions that can develop secondary to certain medicines. It involved, this is not the patient herself, but it developed a condition like this where you get a lot of skin detachment. She also developed organ failure and was admitted to intensive care. She was managed there with fluids, electrolytes, wound management, and various other things. But the cause of this is actually Stevens-Johnson syndrome that has been induced by the carbamazepine drug treatment that she'd newly been started on. And so the most important aspect of her management was actually to remove the causative drug so that her condition could resolve. In fact, it turns out there is actually a genetic variant called HLA-B *1502, and this is a variant that is found in around 10% of the Han Chinese and Thai origin populations. It's also found in some other populations, although it's actually very rare in European and African populations, and that's associated quite closely with the risk of Stevens-Johnson syndrome in patients with carbamazepine. There has in fact been an alert from the MHRA, a regulatory body here in the UK, since 2008 that has recommended preemptive genetic screening for this variant in people of Chinese or Thai origin before starting on carbamazepine because of the association with the risk of developing this very severe skin condition. And so that's been around for a long time. And I just wanted to highlight that this isn't necessarily something completely new. We do genetic testing prior to some medicines, and that's long established now. And so to put pharmacogenomics into practice routinely, what we were talking about is that for the majority of conditions, we currently have the standard approach where a patient is prescribed a medicine for their health condition based on local or national guidance, but quite often at a set dose for the condition as a one-size-fits-all approach. Based on their genetic variation, that will impact how they respond to the medicine, whether they have any side effects. And then after that point, the prescription would then be changed or adjusted to suit the person. So they may have the dose increased or reduced, or they might have the medicine stopped and switched to an alternative until ultimately the patient receives the right medicine at the right dose for them. The proposal that we have and that many are advocating for is the preemptive pharmacogenomic approach, where a patient would have a panel test for a whole range of pharmacogenes just once in their life. This would be a blood test, and those test results would sit on file until such point as a new prescription was needed. And at that point, we'd be able to use that genetic information to select the right dose of the right medicine at the right time for them, and to get to this right medicine much, much sooner. And I'll just give you a couple of examples of this in practice. It has been found that there are genetic variants in something called a mitochondrial RNR1 gene, which predisposes around 1 in 500 affected individuals to a high risk of hearing loss if they're treated with a certain class of antibiotics. A recent clinical trial known as the PALO study, which was carried out in neonatal units here in the Northwest in both Manchester and Liverpool, investigated a point of care test looking for a specific variant in babies with sepsis who required antibiotic treatment. And that was to see if this could be done in such a way that they could deliver testing on the neonatal unit by the existing staff, and also in such a way that it wouldn't interrupt the normal clinical care of this baby, but could improve the treatment selection of the antibiotic. Through this trial, they found that they were able to deliver test results in around 25 minutes, and that enables testing in an acute setting within the 1 hour window that's needed to start antibiotic treatment for a bacterial infection. Of the 751 babies that were recruited to the study, they identified 3 babies with the relevant variant, and therefore in those 3 babies, they were able to offer an alternative antibiotic and avoid potentially the hearing loss that's associated with giving the standard antibiotic to people with that variant. NICE, which is the National Institute for Health and Care Excellence, are currently appraising this technology for introduction into the wider NHS. A pharmacogenetic test that is currently available across the NHS is a test for variation in a gene called DPYD. This was identified as a medicine safety issue because individuals who carry specific genetic variants in the DPYD gene have reduced levels of an enzyme that's needed to metabolize fluoropyrimidine chemotherapy. This is a commonly used type of chemotherapy that's used in around 40,000 people in the UK every year to treat common cancers such as breast and bowel cancer. And chemotherapy treatment with these common drugs in patients with these variants can cause severe and even life-threatening toxicity. And so a new pathway was introduced with a pharmacogenomic test for variants in the DPYD gene before starting them on this treatment. The medical team and the patient would be informed of the results and the potential risk for that patient, and patients therefore at high risk of toxicity could be offered a lower dose or potentially an alternative treatment. This has been estimated to completely avoid the deaths of about 1 in 1,000 people who are affected with these very severe deficiencies in DPYD, and that's around 40 people a year, and to also allow safer levels of prescribing in the around 7% of people who are at much higher risk of toxicity. So it's been a huge win for patient safety. But how do we know if we sequence a gene like DPYD and find a variant, whether it will impact on the person's ability to metabolize the relevant drug? There are many studies that have assessed variants in the DPYD gene and identified 4 variants which are tested for in the NHS based on their population frequency and also on their clinical impact on the gene function and therefore the impact on the risk of toxicity for patients. This is described as a hotspot test, which means we only test for specific changes and don't sequence the whole gene. And the variants that we do test for are shown on the screen here, and they're as advised by the National UK Chemotherapy Board. However, the majority of the genomic studies which this guidance is based on is reliant on data sets like the UK Biobank data, the vast majority of which is based on the genomes of white European individuals. What this means is that there's a lack of evidence to identify variants in genes like DPYD, which may be present in other non-white populations. So although the variants that are tested on the target panel may be found in non-white individuals and ethnic groups, and they will have the same functional impact on DPYD, what we don't know is whether there are other variants which may be incredibly rare in white populations, but found at higher rates in, say, African or Asian populations that would have a similar functional impact on DPYD and toxicity that we don't know about, and therefore we're not currently testing in the NHS. And so approaches to address this kind of bias include huge studies such as the Genes in Health study that's going on here in the UK, in Manchester, Bradford and London, which is looking at recruiting 100,000 individuals of South Asian heritage for whole genome sequencing. There are also similar programs globally across the world, including H3 Africa. And then again, we have local projects here, for example, a collaboration we've got with the University of Liverpool, which is trying to characterise rare variants in DPYD that are not tested for in the current targeted panel test. As part of the DPYD transformation project that was led here in the Northwest, we conducted a series of patient engagement events to get feedback from PPIE groups, but also from individuals with lived experience of this kind of cancer treatment to get their views on how genetic testing impacted their treatment pathway, the kind of information that they wanted about the test, and who and how that should be communicated to them. And as you can see from some of the quotes taken here from the feedback sessions, people in general wanted to have more information that supported their understanding about what a genetic test is, how it would impact on their current treatment, but they were generally happy to be guided by expert clinicians who understood the impact of the genetic variant on them and on their current treatment. They were very supportive that testing could be used to reduce the chance of them having a severe effect to their treatment, and that was a really good thing to have. This is work that we can build on when we're engaging with patients and the public more generally around pharmacogenomic testing outside of the cancer setting. And so finally, one of the NHS England Genomic Medicine Service national transformation projects that's being led here in the Northwest is called Progress, and I'm just going to touch on that briefly. And it's looking at how we might implement pharmacogenetics on a wider scale into the NHS. One of the barriers to testing has been being implemented broadly in the NHS up until now has partly been that genetic variation in a given pharmacogene is generally presented in some rather complicated genetic nomenclature, which is not routinely understood by the average clinician, as you can see on the left here in number 1 genotype. And that's something we're trying to address, is that moving the reporting of the patient's genetic information from the genotype into a clinical phenotype, so that, for example, if someone is an intermediate metabolizer of the gene, in this example, CYP2C19, that result will be presented to their GP or pharmacist in primary care, along with some guidance around what to do with that information for this particular patient in this particular prescribing scenario. So in the example on this slide, a patient requiring clopidogrel, which is metabolized by CYP2C19, if they're an intermediate metabolizer, they would actually have that result presented to their GP along with some guidance, for example, to prescribe an alternative antiplatelet drug. This is a huge multi-year package of work. Year 1 started back in April of this year. Initially, we've been focusing on identifying the appropriate testing technology to deliver the clinical trial. We're also looking at health informatics solutions to present this guidance in the primary care teams. There are huge programs of health economics and implementation scientists alongside it, and critically, as I said, patient and public engagement to ensure the patient is central to this program of work. The next step for us this year is the implementation of the Progress clinical trial in a number of pilot sites, GP practices here in the Northwest, to assess the feasibility of delivering the testing and the usability of the system. We hope to begin recruitment next spring and then in year 2 expand into other additional GP practices around the country. And finally, I just want to thank you so much for the opportunity to present today. Thank you so much for listening. Feel free to contact me, access our website, or my email address is there. Thank you very much. Bye-bye.
So a huge amount to digest there, but some really clear messages about the opportunity that's presenting in relation to truly personalised approaches to medicine and pharmacy, but some challenges too, some of which are really pertinent in relation to the current issues around health inequalities and the importance of understanding the context in which people live their lives, whether we're talking about diets or whether we're talking about general lifestyle approaches. We're going to change pace slightly now, and I'm delighted to introduce Wahida Abbas, who's our midwifery lead for the Northwest, who provides operational leadership for midwives right across the region and is a specialist in blood-related disorders for babies. And as with every approach to looking at health inequalities and population health, we've got here a life course approach, so starting where often life starts, shall we say, in terms of babies. So over to Wahida.
Hi, thank you for the invite. So basically, just want to correct you there. I used to work with hemoglobinopathies, but currently now I'm genomics midwifery lead at GMSA, and also I work 2 days at Bolton as a cultural liaison midwife. So today I'm going to talk about genomics and how it impacts on pregnancy and reproductive health. So could I have the next slide, please? Next slide. Oh, sorry, no, if you go back to this, yeah, so briefly, introduction is just to say that epigenetics, it's very common, it's epigenetic. We see it every day. We don't necessarily relate to it. So linking it between maternal behaviour, experiences during pregnancy and after birth, and also epigenetics, it affects the subsequent well-being of the offsprings and future generation. So when we're looking at epigenetics, we're looking at things that influence pregnancy and maternal outcomes is smoking, alcohol, and drug intake before conception and during pregnancy. The other examples that I can think of is poor prenatal diet, prenatal exposure to domestic violence and maternal distress, and also implications of caesarean delivery, COVID-19. All these things you can link to epigenetics, and that can cause impact on the maternal health, reproductive health, and also on the fetus and when the child's delivered and postnatally and as the child grows through adult health. But because, you know, it's a big subject, is epigenetics, I can only focus on just some of the aspects. So please could I have the next slide? Right, so what I've focused on is I've done this it's like a roadmap and a pregnancy journey. So as they come through the pregnancy, these are the impacts. These are some of the impact. I've not discussed everything that can have an impact on maternal health and reproductive health, which is all in relation to epigenetics. So one of the things it is, which I actually never even thought about, was IVF. So there's a lot of studies in relation to IVF and looking at epigenetics, that how it's associated with fetal growth restrictions where the babies are born small, looking at babies born prematurely, low birth weight, for the gestational age. Also, the epigenetics in during the IVF process can have an impact on cardiovascular malformations and other defects. There have been quite a few long-term follow-up studies that suggested there's an increased evidence of elevated blood pressure and fasting glucose in the IVF babies. And obviously with assisted production, you know, what it does, it kind of remodels the cardiac and vascular areas, and these can have an impact in fetal and postnatal when the baby's born during the development stages as the child grows. And it's a really interesting topic areas looking at IVF, and I think I want to look further into it because it's that really kind of, it's like an eye opener really. So smoking, we all know about the impact of smoking on pregnancy, but actually when we look at that, we never relate it to how it can have an impact as in terms of genomics, epigenetics. So in the period of intra-uterine development, one of the most critical windows during adverse interactions and exposures can influence the growth and development of the fetus. And we know smoking is it's relatively common, but it's very hazardous. And that's associated with prenatal smoke exposure, with reduced birth weight, poor development, also implications for psychological outcomes, increased risk for diseases and behaviour disorders in later life, which are all in epigenetic in nature. So smoking during pregnancy, it's associated, linked with altered DNA methylation, and it's how the genes are expressed that makes the changes occur. So what we can say is that epigenetic, they do affect, you know, the changes in reproductive health in early pregnancy, and also when the child is born, it has long-term impact on, you know, the health of the child. And the other key area is that, which is really interesting, is maternal nutrition, and that's another critical environmental factor which can influence early development, especially when we're looking at vitamin D, not enough vitamin D. How can that impact on the epigenetics? A low iron, that's quite significant. Some of the women, especially from the South Asian communities and Black and South Asian communities, they do have low content vitamin D in the diets, not enough sunlight, and also looking at not enough exposure to sunshine, and also the diet, you know, looking at the deprivation, and this can all have an impact on pregnancy and also in the maternal health. So the maternal diets, and looking at the nutritional compositions, it contributes to the formation of epigenetic profiles, and it can also impact individual susceptibility to certain diseases or disorders in the child in the later life. So even though it impacts in pregnancy, it can also impact the infant in the later life. And studies have shown that maternal nutrition status is closely linked with obesity. So maternal diets also impact the early establishment of fetal and neonatal, which leads to epigenetic changes, and as I said before, it potentially predisposes to the development of late life obesity in the child. And then the other thing I decided to look at was COVID-19, and during the COVID-19 period, obviously the women were confined when they were pregnant, and what happened with that, it induced psychosocial stresses such as like isolation, restricted, you know, social activities, which had an impact on trouble sleeping and the lockdown. So what they're finding is that these psychological social stresses can affect the fetal brain development and you know, the baby's brain maturing. And so there was a call for prompt psychological interventions so to look at that and work with the women to improve the maternal outcome, because it can have an impact on risk and impact on fetal mental disorders, and also, you know, the families the way the families, when they're going through the process of stress, it can have a great implication in the women in pregnancy and also the baby. And the other one I was looking at was alcohol, and we all know about alcohol neonatal abnormalities that commonly referred to as FASD, so fetal alcohol spectrum disorder. So when you look at this, I mean, the epigenetics of this is really, really huge, because obviously the key things are it manifests as growth retardation, facial abnormalities, affects epigenetics, affects the central nervous systems. And even though there is no specific time point during gestation when these harmful consequences can occur, it could happen mostly in early stages, but then can be correlated as pregnancy progresses to more severe congenital disabilities. Also, alcohol, it interferes with the gene expression levels, and that again alters the DNA methylation. And also there's something about impact on the non-coding RNAs, and also which this can have a significant impact in the hypothalamus. So that is it can be quite upsetting for the families, because when you're going through the risk assessment and you're talking about alcohol and how it can have an impact on the pregnancy, obviously these women will need quite a lot of care. And then the other one I looked at was mental health. So we know that maternal stress during and after pregnancy can have a profound effect on development and lifelong function of infants' neurocognitive development. And there's quite a lot of studies that have kind of that point to this evidence. So especially maternal stress during the gestational period, and this can lead to behavioural, cognitive and temperamental disorders in the infant, which increased child morbidity and neurological dysfunctions. So that can lead to autism spectrum disorders because of the changes in the DNA. Also can lead to ADHD, which is a attention deficit hyperactive disorder. So, I mean, to sum up, in conclusion, what I just want to say, it's really important for midwives to have a knowledge base of epigenetics and its impact on pregnancy, and especially when the booking midwife, to take a detailed risk assessment and ensure accurate lifestyle choices are documented when making antenatal, antepartum and postnatal care plans. Next slide, please. Yeah, so this is just showing like the cycle and the mechanism of epigenetics. So these are, if you can see, it starts from the beginning, the fertilization embryo, and then how when you go into stage 2, how it can have an implication of all the tetragenics and nutrition. So it was just like an illustration. Everything goes through the placenta, which passes on to the baby, vertical transmission. And yeah, that's the end of the presentation, I think. Next slide, please. I think that's, yeah. Thank you for listening.
Thank you so much, Wahida. So many important touch points there in relation to how we ensure healthy and safe pregnancies. What a cliffhanger to leave for a break, though. So hold on to any questions. We've got 5 minutes for comfort break, and then we're coming back with Angela Douglas to look at some of the wider context around the social legalistic issues that we need to bear in mind when considering the role of genomics. So go and get yourselves a cuppa, and we'll see you back in 5 minutes.
Congrats, everyone. Welcome back. I think, Joe, if we look at making a start now, just, yeah, I think that's that 5 minutes up.
Absolutely. So apologies if I gave Angela a start. I don't know, the timings on the agenda are throwing me somewhat, and I was trying to add time, and we're actually coming back with Mananza Chowdhury, which is a really important juncture in terms of understanding the relevance of patient engagement and patient experience, and that we need to understand all our populations, not just some. And I think both Jessica and Wahida have touched on that already. So without further ado, over to Mananza to tell you a bit more about her work.
Thank you so much, and good afternoon, everybody. It's a pleasure to be presenting to this meeting. So my name is Mananza Chowdhury. I'm the Patient Experience and Equality Lead for Northwest Genomic Service Medicine Alliance. So for the next 10 minutes, we're going to be looking at tackling health inequalities in the Northwest of England, and in particular working with the British Muslim communities. Next slide, please. So some of our current work, we have a EDI strategy, which is Equality, Diversity and Inclusion strategy, which we put together for the Northwest GMSA. And as part of that strategy, we're translating that strategy into tangible outcomes. And our current number of projects around the Northwest, in particular looking at the Pakistani and Bangladeshi communities and looking at health inequalities within those communities. One of the projects that we have going on at the moment is a project developed by Northwest GMSA and delivered in partnership with the British Muslim Heritage Centre. So I'm just going to really give you a slight insight into what the British Muslim Heritage Centre does. So if you could click on the link, please. So this project is working with the British Muslim Heritage Centre, looking at a number of areas around diabetes, hearing loss, blindness. And this project really is to promote genomic medicine within those particular two groups. So if we move on to the next slide, please. The aim of this project is to engage with, as I said, and increase awareness of genomic medicine, both within the Bangladeshi and Pakistani communities across Greater Manchester. We're engaging with a number of the Muslim faith groups, imams, and the Pakistani Bangladeshi community groups. We're also looking at and working with the imams from the mosques across the region, and in particular with Friday prayers. The recent seminar a few weeks ago, as you can see, self-explanatory there, a number of guest speakers included Afzal Khan, the MP, who is very supportive of this project, and is a very keen supporter of the work of the GMSA. If we move on to the next slide, please. The regional projects and the regional engagement seminars, there are 10 across the borough of Greater Manchester, and I've listed all the boroughs there in terms of the dates or when those workshops will be delivered across Greater Manchester. Now, one of the reasons why we have seminars across the 10 boroughs is because these boroughs have high level of population in terms of the Pakistani and Bangladeshi community. We've had a seminar, we've had a workshop in Bury, and the others will follow according to the timetable there. So we're working across the region. In particular, we're starting off with Greater Manchester, and then we'll be focusing across other regions as we move forward. Next slide, please. Our current other partnership working in terms of implementing our EDI strategy is a partnership with the BAME Assembly. The BAME Assembly is a representation of chief executives and chairs of NHS trusts across the Northwest. And Northwest GMSA is proud to be a member of the BAME Assembly. Professor Bill Newman and I did a presentation on the work of the GMSA back in June of this year. And we're proud to be working with them on a number of projects that we're going to be we'll be putting together, hopefully in the new year. Next slide, please. Our EDI strategy, as I mentioned at the start of the talk, was that we're implementing the EDI strategy through our regional projects and working with each of the project leads in terms of identifying the baseline information, in terms of identifying the gaps within those regional projects. The list of the regional projects that we're currently working with, and identifying the gaps in data so we can target our EDI strategy in a much more effective way, but also to look at where the gaps are and to work with the project leads in terms of identifying and bridging those gaps within the regional projects. Next slide, please. Again, similar work around equality impact assessments across the national projects, and I've listed the projects there. Similar to the national regional projects, we're working again very closely with each of the leads in terms of identifying the baseline, but working with the project leads to look at where those gaps are and to make sure that we have a very targeted approach, and making sure that we're working with some of the most disadvantaged communities. Next slide, please. Our equality impact assessment, this is just basically a diagram in terms of the journey that we've undertaken and the planning that we've undertaken with our program management team. So we've had a very clear plan in place in terms of the equality impact assessments, both across the regional and national projects, and this is in line with our EDI strategy to make sure that we identify what the baseline information is so that each of those projects can feed into a reporting mechanism and have a very clear picture of what's how to implement that work, and look at in terms of the gaps within those services, and also look at what data is coming through. Next slide, please. On the final slide, this is really just to update you in terms of our upcoming work, which is around working with the Deputy Lieutenant of Greater Manchester. This is the Genes and Health Inequalities Project, very similar to the work that we're doing across across Greater Manchester with the British Muslim Heritage Centre. And really, this is a follow-up in terms of really getting working on the ground with some of the community groups and looking at developing a strategy to make sure that we're engaged at the ground level where it really matters. So this work is a proposed work, and we'll be implementing that hopefully in the new year, working very closely with the Deputy Lieutenant, as I said, of Greater Manchester, to really engage with the South Asian communities and look at where the gaps are in terms of the health inequalities, and look at really having a targeted approach with the Core 20 Plus, which is a national program in looking at addressing health inequalities within the Pakistani and Bangladeshi communities. So it basically, this final slide tells you of our commitment to not just implementing our EDI strategy, but also reaching out to some of those hard to reach groups within our society. Thank you for listening.
Thanks so much, Mananza. I'm just aware of time, so I'm going to move swiftly on to Angela Douglas, who's the Deputy Chief Scientific Officer for NHS England and a genomics specialist. Over to you, Angela.
Thanks very much, and thank you for the invite, and good afternoon, everybody. As I've been introduced, I did recently run the North West Genomic Medicine Centre in Liverpool, but since then I've been the Deputy Chief Scientific Officer for NHS England, working with Sohail. I'm going to talk about something a little bit different today. So I'm going to talk about how behaviours and the environment can alter genes and some of the epigenetics, and looking at things related to health, but not actually about health. And, you know, how we consider how our genes might alter our behaviour. Can I have the next slide, please? So I know this is a very busy slide, but it's sort of just an overview of what I'm going to be talking about. And we know that our scientists are developing a lot of understanding around our DNA relates to lots of broad range of traits, and we've already heard about the epigenetic side of that earlier. I'm going to sort of touch on how our genes can impact on employment, sport, criminal justice, insurance and education, as just a, you know, for people to give some thoughts to. And we know that the knowledge of our non-health traits is growing, not as well defined as what we know about health traits, but nevertheless, there's an awful lot of information that's coming through. And so we'll have some impacts on the way that we look at genomics in the future. There's lots of opportunities and challenges that we see playing out in our health genomics, which is also providing us with that sort of window so we can understand some of the potential futures of those non-health genomic areas. And again, we know that our public are gaining a lot of exposure to genomic knowledge, some of that through direct-to-consumer services, as well as, you know, having their own genomes where they have disorders or cancer analysed. And there's an awful lot of research, both nationally and internationally, going on out there. And, you know, we're sort of starting to look at the accuracy of which we can predict people's characters from their DNA. And a lot of that information is now improving, although there's still a long way to go. We also know that we can use technology to edit specific genes using CRISPR technology. And, you know, just because we can, should we? These are all things that we need to be given some thought to. And we know that there are going to be the same ethical, data security risks and all the other social and impactful considerations that need to be given to genomics in non-health areas, as we've been giving to genomics in health areas. So what we do know, both nationally and internationally, genomics is governed by a mixture of what we call voluntary codes and more general regulatory, and not sort of specifically designed for genomics. And so there's very sort of general data protection laws that sort of keep us on the straight and narrow as far as health genomics. But is that going to be enough in the future? So what we need to think about is, how do we ensure a safe integration of that genomics into society around other areas? And I'm going to highlight some of those as I go through this talk. And we do know that there's an awful lot the government needs to do to give some consideration to this. Can I have the next slide, please? So just some questions for you to think about as I'm going through this talk. So how would you feel if your genomic information made your car insurance more expensive, or your travel insurance, or even life insurance? If you could find out whether your child was likely to excel at sport or education or academic pursuits, would you want to know? And should criminal sentences take into account a person's genomic predispositions? And what if genomics impacted on your ability to get a mortgage or a financial loan? Just throwing it out there for you to give some consideration to as we move to the next slide. So those are the possible future uses of genomics beyond health. So what we do know is the genomic prediction of non-health traits is improving, but it's still got a long way to go to be in the same arena as our genomics used for health, as we've been hearing about today. But it's important that we start to realise that there are some potential uses for genomics outside of health. Although we're not using them at the moment, these could be realised in the short to even the medium term future. So what do we need to be thinking about when some of these predictions of genomics come into non-health traits? So what we do know is it's going to be highly complex, just as it is for genomics in health. The research fields in this area are way behind what they are in health. But we do know that there are some applications that are already starting to come into this arena. And it's increasingly important for us to consider how people may apply or attempt to apply the science, and how policy and regulatory systems may need to adapt accordingly. So can I have the next slide, please? So we know we have robust foundations in health genomics. We have our national testing directory, our genomic medicine centres have been well set up. We've got our alliances that are working very well to look at public health as well as population and individuals' health. And we're starting to break down some of the barriers around genomics, and people are starting to understand more about genomics in their own health. And there's lots of compelling genomics research out there. But when we start to look at the ethics and the regulation, there are some ethics that bind around the health genomics, but not so much around the non-health genomics. And there's lots of things that we need to be thinking about, some that are relevant across all these fields, and some that we need to be thinking about that may be just specific to individual fields. So we need to be thinking, do they cover practical issues relating to data privacy and security, the social issues like inclusion, fairness and choice, and any scientific issues such as the diversity of populations that are represented in the genomic data. And I'll say a lot about some of these things as I go through my talk. Can I have the next slide, please? So what we do know is that the regulation that surrounds genomics in fields beyond health is lacking. So I've already mentioned that, and there's lots of risks that might be linked to this. But in the UK, we've done an awful lot around population genetics. So we understand quite a lot about genomics, how the environment influences, as we heard earlier, metabolomics and transcriptomics. We know a lot about the pharmacogenomics, as we've have heard earlier. And that puts the UK in a unique position to lead genomic research globally and sort of capitalise on developing some of that infrastructure that we already have in place, that wealth of genomic data that we have around health services and scientific studies, and how we can use some of that knowledge to adapt it to some of these other areas outside of health. So there's a real opportunity for the UK to lead internationally on regulation, law standards relating to genomics in fields beyond just the health that we are currently working quite a lot in. So can I have the next slide, please? Now, we've already sort of heard a little bit about genomics and the impact of different inequalities in genomics. But one of the things that, perhaps we need to also highlight here is a lot of the genomics that's been currently undertaken, especially during the 100,000 genomes and some process and beyond the 100,000 genome projects in other countries, has largely been with white Caucasian individuals. So a lot of the data that we're basing some of our predictions on are based on European ancestry. So again, what we're doing is we're basing all of our predictions that could be inaccurate on that European ancestry. And maybe what we're doing is we're sort of entrenching that inequality or even contributing to it. So we need to be giving some thought to that and expanding the numbers of sequences as we are doing, but to ensure that we are expanding them and making sure that we have a ancestries across the whole world that we can pull that information from in order to start to make more predictions around not just the health genomics, but also non-health genomics. Can I have the next slide, please? So what I'm going to do is I'm just going to give you some examples so we can start to consider some of the possibilities. Now, some of these things are already in play, and some of them are just starting to sort of work their way in on the periphery. But nevertheless, in a very short space of time, some of these considerations may become reality. So I'm going to start with my next slide, which is sport. Genomics and sport. So we already know that there are lots of genes that can predict endurance performance, that can predict power performance. We know that genetic tests already currently are undertaken to screen for health conditions and that might pose a risk to athletes, and also for sex verification in international competitions. We know that there are genes such as the EPOR gene that are associated with elevated red blood cell count, generating 25 to 50% more red blood cells than usual, which confer an added advantage to those who carry that particular variant. We know that there are direct-to-consumer genomic tests out there that identify athletic potential or inform training regimes, although we do know that they're not regarded as accurate or even useful, and they're not that much in use by prominent sporting bodies. But nevertheless, those tests are out there. But in the future, with gene editing, techniques, they could be used to potentially enhance the performance of individual sportsmen. We do know at the moment that the World Anti-Doping Agency has preemptively outlawed gene doping and is trying to develop techniques to detect it. But nevertheless, this could be a future that we may need to give some consideration to. Can I have the next slide, please? So the other area is insurance and insurers. So in the future, insurers might seek to use, for example, polygenic scores for heritable behaviour characteristics, such as, your risk-taking behaviour, or whether you are susceptible to injury, or whether you have a predisposition to some late onset genetic disorder. Now, at the moment, we do know that there is a moratorium with insurers that they cannot use this, and generally in the UK, the insurance industry follows a voluntary code setting strict limitations on the use of health-related genomic information in determining people's eligibility to insurance. But we also know that there are an increased availability of direct-to-consumer genomic tests that give people an indication of any information about predisposition to diseases and disorders and other behavioural characteristics. So there may come a time when we as a population or as customers know more about our health and the prediction of our future health than our insurers do. What research is showing that there'll be they're predicting that there'll be critical illness claims that could increase by an average of 26% the use of genetic information in underwriting your insurance claims if it's not allowed to be used as part of that insurance ask. Can I have the next slide? So then that takes me to the next area that genomics could possibly be used in, and that's employment. So at the moment, it's not used quite, to any great extent. There are limited circumstances where it could be used in employment. But this is a rapidly growing area, and it could also prompt employers to use genomics more widely. For example, they could use genomics to select workers for optimal health or personality traits, or for a particular role, or to prevent, looking at those who may have a predisposition to injury to actually prevent workplace injury. And the use of genomics in assessing candidates' personality traits, which is quite controversial, but in the future, that's also an opportunity that could come about. And we do know that there are personality traits that are reasonably influenced by the genome. That is that, they are inheritable. So, for example, things like extroversion or neuroticism, agreeableness, conscientiousness, and being, openness to experience, all of these things do have a genetic composition behind them. And again, there are tests that have been designed to predict these traits, and but they do we do know that there are sort of technical and ethical barriers to these being used in employment at the moment. But nevertheless, there isn't any explicit legislation around the use of genomic analysis in employment scenarios. So that's something that, the government may need to give some consideration to. We do know that in America, there is a non-discriminatory act that prohibits the use of hiring people or putting people under redundancy or placing them in different roles, or even promotion of ill health, or using ill health as a promotional disadvantage or a decision. But nevertheless, in this country, that doesn't exist. Can I have the next slide, please? So another area is genomics in education, and there are thousands of genes that have been identified that actually relate to educational and cognitive outcomes. And, again, direct to consumer tests are available where parents can actually have their kids tested by saliva samples, which give them an indication, of whether that child is going to have a polygenic prediction of being, academically brilliant or not. And is there going to be, does this help? And it may be, if we consider this as an early intervention, so if we know about this in our children early enough, then it can provide us with an opportunity to put interventions in place to improve their educational outcomes. But nevertheless, there are no regulations that govern this. Can I have the next slide, please? So the next one I was just going to highlight for you to give some thought about is genomics in the justice system. Again, there are some variants that have been associated with behaviours that are linked to criminal behaviour. For example, the MAOA and CDH13 genes, which have been associated with aggressive behaviour and have been found more predominantly in those in high security prisons. Things like substance abuse, although it's not, a crime, addictive behaviours are, again, heritable and can, there are estimates of heritability of cannabis addiction, alcohol dependence, and cocaine use disorder. So all of these things, we can find out about. And, developing polygenic scores for susceptibility to substance abuse is a real possibility. Can I have the next slide, please? So sort of continuing on the theme of the justice system, again, genomic data has been raised as a mitigating factor in some court cases, not in this country, but in other countries. And, it may become more common as more of the evidence starts to improve, especially around polygenic scores. We know that, we can analyze polygenic scores and give a prediction of people's hypertension rate, or whether they're more likely to be aggressive or more likely to get angry, more than any other individual. There is no precedent in the UK for using these in court cases, but nevertheless, there is no legislation guiding against it. So youth services, social service, or police may seek to explore the use of genomic prediction to deter or divert those who may be predisposed to criminal behaviour. And polygenic scores, as I've said, can estimate the likelihood of lots of traits that could manifest in this type of behaviour. But the important thing here is, if we do this, then it conflicts with the presumption that we have in this country of you are innocent until proven guilty. Can I have the next slide, please? So this is my last slide, and just to highlight that Patrick Vallance has written a report, there's a much wider report on all of this that's on the gov.uk website. So in summary, there are no certainties as to how genomic technologies will develop in the future, or how people might attempt to use our genomic information, or how we might decide we want to, or how much more might decide we want to know about our genomic information. However, the direction of travel is starting to become clearer, and now's the time to consider what might be possible in the future and what actions government and as health professionals we might want to take to maximise the benefits to our public and our population, but also to mitigate the risks of our growing knowledge in this field. And I'll end it there. Thank you.
All I can say is, wow, Angela, as Rachel said in the comments, it was mind-blowing, such a comprehensive coverage of so many interrelated issues, and so much food for thought. And I would like to suggest to colleagues that we continue this conversation in the new year, perhaps in some more public venues, and harnessing some of our perhaps museums where they're very used to addressing issues around health justice and social justice agendas, because as my mum used to say, if you fail to plan, you plan to fail. So we need to have these conversations when not everything is at stake. It's about that planning role, isn't it, and that reflection. So again, in terms of nature v nurture, I almost was thinking in relation to self-fulfilling prophecies, because if we only have half the scenario, we can inadvertently reinforce pre-existing inequalities as well. So I'm just looking to see if there's a last comment. We've got 2 minutes, or a question. Does anyone want to ask, while we have all these experts in the room, be it virtual, a quick question? But definitely we want to do more with our midwives, certainly in Cheshire and Merseyside, Wahida, and more generally in terms of having more of these structured debates with conversations.
Was that a question?
So everyone's agreeing about doing more. Any questions?
Yeah, I'd like to ask one if it's okay.
Brilliant.
I'm David. I work in NHS Merseycare for the Life Rooms project. So, just briefly for anyone who doesn't know it, we're obviously the arm of the NHS or Merseycare, which is helping people through social prescribing. So it's really advancing the theory of preventative measures and mental health, as the main two things for determining lots of other things. And with something like this, I mean, this is great information for us, because it does boil down to the fact that regardless of the genes, they're only expressed in a negative sense, due to trauma or fear, environmental factors or societal factors. And that's great, but then there's still a fork in the road there in terms of how we could possibly aim to use that information. And I feel it's going slightly one way a little bit too much, the emphasis on like the pharmacological and the treatment at the end of problems rather than the prevention. And the prevention side to me looks like more research, more studies, more emphasis on how we look after the mind of a person, so that stressful factors included, trauma included, with everything in the mix, the mind at the end of the day is the thing that's gonna determine whether the genes actually express negatively or not. And so it crosses over then into other forms of healthcare, which is like the final frontier, isn't it? And I just really hope that it's used and it gets momentum in that area. Mindfulness isn't just this fringe spiritual sort of like rainbows, unicorns thing anymore. It's a serious thing in terms of some and that's just mindfulness. There's others, but there's something serious about the knowledge that we need on how to manage the mind, and especially with this information. So I just wanted to put it out there that I hope it's used in that way, to go in that direction, as well as pharmacological and treating conditions once they've arisen.
What a profound commentary, David, in relation to the importance of prevention. We're too keen, aren't we, to respond when people are broken, and we do need to work much further downstream. So we've run out of time and we are losing some of our speakers who've got other engagements, but there is another question in the chat, just really to help us to understand how far you've travelled. And I think we're taking it that we have a level of agreement that we do something else in the new year to build on this, whether it's through Health Education England or through a partnership of activity. But I certainly am aware through social prescribing, there's definitely an appetite, David. So you're not on your own. And we can perhaps engage separately after this activity with me wearing my NHS England social prescribing hat. So if you wouldn't mind completing the quick question, and then do revisit the Northwest Population Health Prevention website. The recordings will be up there. And also, I mentioned earlier, the GMSA website. There's some really fascinating resources and really materials that can help you go back to your workplaces and become champions for having these conversations. So we're not leaving you, as it were, after this session. There are those resources for you to access them. So continue the discussion and don't forget to fill the survey in for us.
Thank you, everyone, and apologies again about the question and answers at the end, but we will ensure that we go through the chat and we pick up the questions that have been asked. And if anyone does have any questions, put them in the chat now or email phpm.northwest@he.nhs.uk, the one you'll have received the communications from, and we will pull them together and share them. But for me, just thank you to all our speakers. That was all great. I think we could have probably ended up having an hour discussions after it. There's a lot to digest. There's a lot of new information, and yeah, all the speakers, thank you so much for the time and effort you put in. And you can see sort of from the chat there, it's all gone down very well. So thank you.
And a huge thank you from me as well. Really brilliant content and really, well, just food for thought. And I think we just need to do more.